and for whom there wouldn't be adverse reactions. And maybe you could have a protein one or a DNA or an RNA one for the more vulnerable, the elderly. And perhaps in that way we could deal with also providing access to the vaccine quickly. And I'd also like to comment a little bit on what you mentioned about countries maybe overstepping ethics and just going ahead with the trials on humans. As you said, I also agree. I think this is very unethical, but unfortunately there has been a politicization of this situation where this is kind of a race. If I dare like compare it to maybe like the space race there was during the Cold War, where these big countries want to show that they've got the scientific capabilities to solve this problem. And of course then the people who are put in danger are the common people, and this could also very much give rise to anti-vax sentiments, which are already rampant. So definitely we should leave these things to the experts, to the scientists and the physicians, and not to the politicians.
Yes, you're right. And on the one hand, we can be very lucky that we have more than 130 candidate vaccines in development, because we know that probably from those candidates, only perhaps 6 to 10 will reach the level of having shown that they are efficacious, that they are safe and immunogenic. But we will need all these vaccines. So we know that some people think, okay, we produced a vaccine for our continent. So that's also something that we will have to think about. How are we going to accept that? I don't know whether we will have the choice even to say, look, that vaccine is for the younger one and that vaccine is for the older one. Perhaps we will be very happy if we have a vaccine per country. But it's good to have, of course, a number of people or a number of vaccines being developed, because the competition on the one hand also helps the companies not to lose time and to really be active development, in the data generation, in the analysis. And so we will really move forward to a quicker development than usual. And it's already a race, as you said. It's also a political race because, of course, some countries really want to show how well they are. And I like the comparison with the first man on the moon. It's really like that. They are in a kind of war against a virus, and they want to show that they are the best equipped and they have the best weapons and tools to fight the virus. And in particular in those countries like in the US, where of course there is a lot of critique on the way how they handle the epidemic. So they want now to try to save their face by showing that they are able to develop the quickest a vaccine. So there is a lot of political game also there, unfortunately, but that's part of life.
For sure. We actually have
chat.
We have some questions in the chat, so maybe we could address those. Thank you for your questions. We've got a question from Thomas, who's asking, what are the reasons for never having had any licensed vaccines against any of the coronaviruses? Of course, we know there was a SARS outbreak and also MERS later on, but we don't have vaccines for them. And also, how can we be sure there will ever be a vaccine? Yeah.
Good questions. So I would say I'll start with the first one, and with the second part of the second one and the second part of the first one. That's a very realistic question. Developing a vaccine is always a trial and error development. So there are a lot of go no go situation, and all depends on first the results from a phase 1 study, a phase 2 study, and a few companies are now already in a phase 2 study. And I think you know what the differences are, but the phase 1 is really the first use in human, which means it's the first time you will also try to demonstrate safety and the ability to develop antibodies in a small group, usually 50, 60 people. And in the phase 2, you do exactly the same, but then already in a larger group with 500 people. And sometimes you start also to look at the effect of doses, a different schedule. So that's okay. And then comes, of course, the most tricky part is the phase 3 study. And for those of you who follow the news in the UK, they are planning a phase 3 study with their vaccine, the vaccine developed by a team in Oxford. And they are now struggling. Why? Because in a phase 3 study, which are large studies, usually above 3,000 subjects, 50% receives the candidate vaccine and 50% receives a placebo vaccine or another kind of vaccine. And then you measure naturally the protection rate. So between those who receive the candidate vaccine and those who receive the other vaccine. But that means you need to have enough disease. And so as every country is fighting against the disease and the incidence is lowering, at a certain point in time, you're not able to show that perhaps a very good vaccine is working. We have seen the same situation with Ebola vaccines in West Africa, where the first vaccine that was used there was still at the moment that the epidemic was quite important. But the second vaccine arrived at the moment that the epidemic was disappearing. And then you don't have any statistical power anymore to show that your vaccine is working. And that's I would say the challenge now for those companies who are very fast in the development of their vaccine, that they start to realize that a phase 3 in Europe or a phase 3 in China or a phase 3 in the US will be difficult. They are now thinking to do their phase 3 trial in Latin America or South America. But perhaps by the time it is approved by the ethics committee and by the regulators, there is also no epidemic anymore. This is really challenging. So I understand the question that how can we guarantee that we will have a working vaccine? Well, even a step earlier, it's even difficult to show that your vaccine is working. And that brings us to the situation where, and that has been discussed for COVID-19, you can do these challenge studies. And it has already been done in the past too. So you have 30 subjects and you will bring them, you will vaccinate half of them, and the other half receives another vaccine or a placebo vaccine. And then you put them in quarantine and you expose them to the virus. And you can quickly see whether your vaccine works, yes or no, because if the vaccinated people are well protected, you will see nothing. And if the unvaccinated people are not protected at all, you will see all the disease in that group. Is this ethically acceptable? That's another issue, because in fact, you only can do these kind of challenge studies if you have a medication to treat them. And that's the other thing. We don't have a medication to treat them. So that again postpones the plans to have quickly a vaccine. So I fully agree with these critical questions. We are not yet there. So we have to solve many, many more issues to be able to have a vaccine by the second half of 2021. Why don't we have vaccines yet against corona? It's another very good question. First of all, we do have these benign corona viruses that only causes a kind of common cold. So that's not a reason to develop a vaccine against common cold. But we do have candidate vaccines against SARS-CoV-1 and against MERS. These are really candidate vaccines, but because of the fact that these diseases were more or less controlled, there is less interest, scientific interest, but also financial interest from international organizations to invest in these vaccines. And so some part of that research just stopped. And one of the candidate vaccines now against SARS-CoV-2 is based on a previous candidate vaccine against SARS-CoV-1. So there is still material that is used now for the development, but indeed it has never gone farther because SARS-CoV-1 suddenly was no longer an issue and it was no longer an epidemic. And then all the academic interest and financial interest disappears. And that's maybe also a lessons learned for this pandemic, that we have to invest much more in preparedness. Okay.
Okay, so maybe we could go on to the second question in the comments. Thank you for that as well. So this week, Chinese scientists have created a new mouse knockout model for COVID-19 studies. Can we expect this new model to quickly leave China and contribute to studies in laboratories around the world?
Wait, I don't see the slide with the question. Can you?
Oh, right. This is the other question that was in the chat. Okay. So this is in the chat.
I try to find the chat then, because I don't see it on the chat.
I can read it out again slowly.
Yeah, otherwise you just read it again.
Yeah. So this week, Chinese scientists have created a new mouse knockout model for COVID-19 studies. Can we expect this new model to quickly leave China and contribute to studies in labs around the world?
Well, I think it's an interesting model indeed, but the issue remains a bit what we know with other knockout models is that what about the extrapolation? How can we try to to use this as a proof really that that vaccine will not only work in humans but also protect humans? And then I think it's more convincing to look at what other Chinese researchers have done 2 weeks ago, or published 2 weeks ago in Science, showing that their inactivated vaccine was able to protect macaques. And that was quite convincing because it was also shown that there was a dose relation and that the higher dosed vaccine protected better than the low dose vaccine, so creating better quality, but also a higher amount of antibodies. And that those macaques that were not vaccinated really suffered very similar complications like interstitial pneumonia as humans. And that's, of course, a nice model to follow also what happens and how well you can try to show protection. So I think if we are not able to do these kind of challenge studies with humans because we don't have any therapy, and we are not able to have these phase 3 studies, perhaps we will have to extrapolate these kind of non-human primate studies as best proxy for protection.
Definitely a very interesting concept. And then there are, of course, again, all the socio-political aspects of access to information and sharing data and making sure that people in different parts of the world don't, repeat work unnecessarily. So I think that's why it's very important for the World Health Organizations and other major stakeholders to kind of pool data together and get people working together to get this accomplished quickly. Yes, I think we could move on to the next question, please. Okay. So, how are vaccine testing and trialing processes geared to ensure that the vaccine has very few adverse effects? How do we best communicate the safety and efficacy of the vaccine to patients? So this comes back to hesitancy and how we can really combat hesitancy as healthcare professionals and as future healthcare professionals.
I think that's very important to address these items in communication, because people start already now to question the vaccines in all parts of the world. I heard this morning in another teleconference that in Africa they have printed already T-shirts showing "No COVID vaccine for me." Can you imagine? And that's because they think that the vaccine is developed in a too rapid way, and then you will not be able to show safety. So it's tremendously important to explain how we can work faster, why we can work faster, but that still safety is one of the cornerstones in that development. And that we still do these preclinical research, the animal testing, the phase 1 and phase 2, and that is a normal process in the development of a vaccine. And people need to understand that. And if we don't communicate very well, I'm afraid that people don't want to be vaccinated, and because they don't trust the whole fastened process. So we will have to address that in the communication. I think the way we can guarantee safety is exactly to emphasize that the development is very similar to the development of another vaccine. In particular, if we use existing structures or existing platforms, the same, for instance, as for Ebola vaccine, if we use the adenovirus platform, the measles platform is one that is used also for other vaccines, or the inactivated platform is very interesting as well, because that's a very traditional one. So we will have to explain people that we started not from scratch, but from existing platforms, and that might also help the communication on safety. So we have to reassure people that everything is done, in fact, to do it the right way. Of course, more rapidly because we need a vaccine, but we will not sacrifice safety to have a more rapid vaccine. And that's key. And we have to start, in fact, already today in that kind of communication.
Yes, for sure. I think there might also be the effect of if your country, your particular government and the people in charge did a good job with managing the situation, the public is more likely to trust them when they say take this vaccine. Whereas if the government was not seen as controlling the situation well, they might be more hesitant. So I guess that could also affect, and that's why we could have like variations from one country to the other on uptake.
Mm-hmm. You're absolutely right, and of course you can easily criticize everything. In particular today, if you would have known 2 months ago what you know today, then it's very easy to criticize, and that's what is happening in all countries. If you look at websites and newspapers, also today in Belgium, suddenly now people start to be more critical. Why? Because we are in another wave of the epidemic. It looks like everything is under control, and now they start to criticize the politicians, they start to criticize the scientific experts, and that's as you say. They also start to criticize, for instance, when there is a vaccine, how are we going to get a vaccine? Will it be the same mess as with the testing issue or with the mask issue? So they start to compare this kind of situations, and you're completely right. People will compare with what went wrong, and also that needs to be addressed in a correct way. And I think as we have time now between this moment and perhaps over a year when the vaccine might be there, we should use that time to think about how are we going to create a good policy in terms of vaccination, to create a good awareness, to create confidence, and how to communicate. And we should prepare that right now. And we have time to do that. And not to start to do that at the moment the vaccine is there, because then, again, I'm afraid mistakes will happen.
Agreed. Yeah, so I think we can move on to the next question.
That's just the two previous slides were just to show how fast you can go. It's a very nice picture from the New York Times, where you see the usual development time, and then the next slide shows, in fact, how we can try to reduce that to fasten the whole process.
Yes, I highly recommend that article as well. It's extremely insightful, and also it's got tools in it where you can amend different things, and it's very interactive. So, yeah. So, question 3: how have previous pandemics, such as the 2009 swine flu pandemic, affected international collaboration on vaccination? Has it contributed to the hastening of production of the COVID-19 vaccine? And furthermore, and perhaps we should focus on this part of the question, how do you think that the COVID-19 vaccine development experience will affect the production of other vaccines in the future, especially in a potentially other pandemic setting?
I think this is a key question, and even almost a philosophical, political question, because if we look back at the situation 2009, 2010, we should have learned much more from that situation. And I can refer to Bill Gates, I can refer to Peter Pio, to, I think, important people who in 2011, 2012, has urged the world and the politicians to invest much more in preparedness for pandemics. And in fact, nothing has happened. And that's what you all experience, is how prevention in general in our medical education is treated very stepmotherly compared to curative medicine. And we all know that more than 90% of our medical curriculum is based on curative medicine. We start from a complaint and then we do something. Prevention is the opposite. You don't wait for something, you just prepare yourself and you invest in health. And that's what we don't do enough, not at the level of the country, not at the level of Europe, not at the level of the medical education. In fact, we wait for a crisis and then we start to do something. And that's purely a curative attitude. So we should much more invest in how to prevent a crisis. How can we be prepared that if a crisis occurs, we don't have to suffer? And that's what we should have learned from 2009, 2010. And I agree, it's very easy for me now to say that. But I hope that this current crisis, this time, will create the lessons learned with much more investment in prevention, in surveillance for this kind of diseases worldwide, in contact tracing, which we start to consider now as the first line of defense in the crisis or in the epidemic. But in fact, a lot of countries have reduced all their investment in this kind of contact tracing. We only apply that for maybe tuberculosis in some countries or for sexual transmitted infections in other countries. But in fact, we should have a system that can be activated related to this kind of contact tracing, because that's really key in these kind of pandemics. And in particular, if we know that we can expect new pandemics with flu. So we should now really much more be prepared and construct instruments, networks to survey all these elements. Another lessons learned will be, and that was also the situation already in 2009, 2010, is, and we refer to that, is how are we going to distribute equally and with a lot of equity vaccines once they are there? So how are we going to be very fair and organize that vaccines will also be offered to an African country where there is no production facility at all? This is, of course, the role of the whole global community. And we see that today, even at the level of the EU, it's very difficult to find solutions. And so the World Health Organization already put people together, the 6 continents and a lot of countries together, to think about this. And I think it's the right moment indeed to try to discuss a strategy, because a strategy in 2009, 2010 didn't work. And those who paid most received vaccines. And those who had no budget at all had no vaccines at that moment. So this is something you cannot allow, because in particular, if we have enough countries that remain vulnerable, well, the virus will continue to circulate all over the world. So if we want to get rid of this virus, we need to have a solidarity between all the countries and all the continents. And that's easy to say, but very difficult to achieve. So one of the elements we can learn, and I think this question really refers to the lessons learned, is to the revolving fund system. It's a quite interesting system that works in Latin America and South America. And for more than 30 years now, they have this revolving fund for their EPI vaccines, so for the vaccines that they offer during childhood. And so all countries pay a certain amount to the fund, and the fund redistributes, well, first the fund buys for vaccines, and then redistribute the vaccines to all the countries according to the number of births in the country. And it works. They use it for their measles vaccine, for their polio vaccine, for their pertussis vaccine. They don't have to fight with each other. It's a system that works for more than 30 years. And they can even negotiate a very sharp price with the companies because they are ordering vaccines for more than 30 countries. So it's amazing. So I hope that this kind of construct can also work at the global level or continent per continent, where you say, okay, you pay a certain price, and you can even say that the rich countries pay a higher price than the low and middle income countries in that fund. And then the vaccine is distributed with a lot of equity, first to healthcare providers and to the vulnerable people. So that could be a lessons learned from other models. But again, this should be thought about at this very moment, and not at the moment that vaccines become available, because then you start to fight to get the vaccine, and that's not the right way. So these are very important experiences.
For sure, foresight is always extremely important, because human beings, our natures, we're very short term, and you know. So, and also this morning there was quite a heavy blow dealt because President Trump actually announced that he's going to be withdrawing America, the USA, from the World Health Organization, and they are the biggest contributor of funds to the World Health Organization. So that might make this equity issue even more aggravated and make it more of a competition, kind of who gets the vaccine first, and richer countries will inevitably win out if someone that like an entity that advocates for the rights, like the World Health Organization, has become crippled due to the actions of the USA. So it's there's a lot of unknowns, and we really have to wait and see.
And the amazing thing is that the China is willing to increase their contribution now to the World Health Organization. So, and you see that the power between these, or the fight between these two large countries, is continuing even at that level. So it's not only visibility, it's not only development of vaccine, but it's now also, of course, the power that China says, okay, we increase our participation, and then the World Health Organization will suffer less. But that means also that the influence of the US in the World Health Organization will decrease. And that's a, you can say, okay, that's an advantage. You should know that a lot of CDC people, very well-trained people, assist the World Health Organization in a very important way. So if that support suddenly were to disappear, that would be terrible, because these are not, I would say, Trump fans. These are people with brains and well-trained, and they really want to help low and middle income countries with what they can offer in terms of really CDC experience, whether it is lab or epidemiology or control of infectious diseases. So that would be a pity.
Definitely. Okay, so I think we can move on to the next question. And for the next question, we would actually like everyone to contribute. This is a very vague question, and we would just like yes, no answers. So kindly type yes or no to this question in the chat, and then we'll have a bit of a general idea what our attendees think. So the question is, do you think that the world can overcome COVID-19 without a vaccine? So please put your answers in the chat, and then the professor and myself will discuss the answers. Okay, so we've got quite a few yeses. Yes, in the long term. Yeah, baby. What else? Yes, but with time. So yes, it's predominantly yes. Let's see. Okay, and also feel free to elaborate on your answers. So I'm sure you guys have reasonings for why you think yes. Someone said it's hard to say yes when we believe in vaccines, and that was kind of the standpoint where I was coming from, but lots of yeses, a couple of no's. Okay, so I think we can discuss the answers, and please feel free to keep sending in your answers with your reasoning. Yep. So what do you think, Professor Van Dam? Will the world be able to overcome COVID-19 without a vaccine?
Well, if we allow this, I would say, then that means a lot of people who will have to suffer COVID-19, because that means you will count on what is called herd immunity. That will be the only way to get rid of the disease. If you have more than 50%, most calculation will say 60 to 70% of the people need to suffer COVID-19 and to develop immunity against COVID-19 to get rid of the virus, so that you really can count on herd immunity. And that's a lot of diseased people, probably a lot of hospitalization and a lot of deaths on the one hand. Now, the second thing is that it's hard to count on herd immunity. Why? Because we start to realize that the virus does not spread that easily in the community. And people thought, oh, if we don't take very tough measures, like first in the UK, also in Sweden, perhaps we can have this immunity growing very quickly to 50%. If you have seen the latest data from Stockholm from beginning of May, they have acquired 7.5% in their population in Stockholm. So it's a very low so-called herd immunity. So that's one thing. So it goes as a cluster epidemic. So really from cluster to cluster, and it's not an equal spreading all over the population. And that's something we need to take into consideration. The second thing is that once you have suffered COVID-19, you develop antibodies, but we don't know what the quality and the effect is of the antibodies. And that sounds very pessimistic, but that's true. So we expect these antibodies to protect us for the next wave or the next exposure to COVID-19. But in fact, we don't know that. There is no scientific evidence for that. And research is ongoing. We know in the lab that the antibodies are able to neutralize the virus, but we haven't seen that in the natural environment. That's one thing. The second thing is that not everyone develops antibodies. In particular, those who have almost no symptoms. Of the Pauci symptomatic cases, they will develop a very low concentration of antibodies or no antibodies, and those antibodies will disappear after 1 month. And then the question is there something else that protects us against COVID-19 than antibodies? So that also needs to be looked at. Can we count on cellular immunity? Is there immune memory? So that's something we don't know yet. And that's equally important if we count on herd immunity. So having said that, I must say that most experts expect that the only way to overcome COVID-19 is that we need a vaccine. And that we replace, I would say, the natural immunity or exposure by an artificial herd immunity by offering the vaccine broadly. But that means then we really need to have enough vaccines. And that's not millions of vaccines, but it is billions of vaccines. And we need to reach at least 60 to 70% of the population. We know this is not easy, but it's easier than measles because there we have to reach 95% of the population. So let's say it will be a challenge, but if we don't do that, we know that we will have a second wave, a third wave, probably a fourth wave, so that it can continuously come back. And we know that the mutation rate of COVID-19 is not comparable to flu, and that we expect that we have a new COVID-19, so a mutated COVID-19, perhaps over 3 or 4 years. And then we are in a situation that we will have to vaccinate every 3 and 4 years the population, like we do annually for flu. But the mutation rate is much higher for flu, so we need to do that much faster for flu because we have every time another flu virus. And with COVID-19, it might be that we have every 4 years a new COVID-19 mutated virus. So a lot needs to be looked at, but just to tell you, it's not an evident question, it's not an evident answer neither.
For sure, and it's very interesting that we mentioned herd immunity and also the different ways that different countries are handling the COVID-19 situation with restriction of movement, with isolation and such things. I think this actually goes into our next question. The next question. Yes, there we go. So I think we could very organically continue our conversation. Let me just read out the question. So different countries have taken different approaches to the situation, some shutting down everything in an attempt to curb the spread and wait out the development of a vaccine, while others have embraced the herd immunity approach. So the herd immunity approach has proven costly in terms of lives lost, but is it a complete failure, or will people who contract the virus recover, develop a more formidable immunity than vaccinated people? So I think we've discussed a lot of these points. Maybe we could focus on from other viruses that we've had before. Natural immunity seems to be more effective, but as you've already mentioned, perhaps that might not be the case in this situation.
Well, if we compare with the benign coronaviruses that we all have experienced, and that goes not more than just a common cold, we know that these viruses, or that we don't develop a long-term immunity against these viruses. So from that end, I would say if we compare with those coronaviruses, probably I must say that the natural immunity will not be very protective. Of course, on the other hand, what we see in the lab situation shows that we are able to neutralize the virus with the natural antibodies, but the question remains, how long are we able to do that? So how long we have to follow the kinetics of the antibodies over time. And we started a study with the Antwerp Tropical Institute with a cohort of hospitalized COVID-19 and ambulatory COVID-19 patients, and we bleed them every month to follow the kinetics of the antibodies. So after over 2 or 3 months, we will know more about the presence of the antibodies and the quality of the antibodies after so many months. So that will be quite interesting as well. But so far, we don't have enough evidence to say that the natural immunity will be protective, whereas the vaccine-induced immunity has been shown to be protective, at least in macaques. So that gives us a good feeling that with a vaccine, we might be able to produce a better immunity than after a natural exposure. And maybe some of you might say, oh, that's very strange, because usually we are told in our courses that, for instance, with measles, if you have experienced measles, your natural immunity will be much stronger and longer than after a vaccine immunity, which is true. But there are other diseases. If you take human papillomavirus, women who are exposed to human papillomavirus, they will have, in 50% of the situation, antibodies, but 50% of them will have no antibodies. And if they have antibodies, we know that these antibodies are not able to protect them against a new exposure of human papillomavirus. So this is not that strange. So we have other diseases where the vaccine-induced antibodies, because the HPV vaccine-induced antibodies do protect and have a very high concentration of antibodies. So in that situation, we know that a vaccinated woman is better protected than a woman who experienced a natural exposure to HPV. And we could have the same with this virus, with COVID-19. So that still needs to be well understood. The other thing I want to say is that if we compare a number of countries with, for instance, Sweden, where they purposely did not have very strict lockdown measures, and I think that Sweden has been criticized, and we have to be very careful because each country is different. And we have to understand the measures according to history, to demography, to health system, but also to the population density. If you look at the population density in Sweden, it is 26 per square kilometer. If you compare that with the situation in Belgium, for instance, that is 14 times higher. So I used to say now to my Swedish colleagues, and we do have some teleconferences, that they constantly live in a kind of physical distancing situation, because they are spread all over the country, in particular, of course, those who don't live in Stockholm. But that explains a lot, and they agree. They say, if we ask the people to respect a distance of 1.5 meter, it's not a problem, because they say, well, we are in bubbles and we live outside Stockholm in our bubble and we don't meet a lot of people. We are used to that. And when we meet people, we don't kiss. They are a little bit more from a distance than, of course, a lot of other Mediterranean countries where they will start to hug and to kiss, and myself, I'm like that as well. So we have to change our attitude much more than in some other countries. And also that explains a huge difference in epidemiology, on top of many other things. I would say, if you look at the start of the epidemic, the number of measures you can take in the beginning of an epidemic, if you start to control the number of cases from the start, you will have a much bigger impact than if you have to do it at a later time in your epidemic, and then you really have to switch to a lockdown. So it's quite interesting to look at the situation in each country, but it's very hard to compare countries with countries.
For sure, definitely there are the cultural aspects, but also the actual geography and human geography. I actually did a quick Google search to check Malta's numbers, where I'm from. So for you, the people who don't know, Malta is a tiny, tiny European country, and we have 1,562 people per square kilometer. Something like what's happened in Sweden could definitely not work here. Plus, we're also Mediterranean. We're very friendly. We like to get up into people's faces. So I completely agree with that. Okay, so let's go into the next question.
Yeah, I see a question also in the session.
Mm-hmm.
I'm just looking at what is said there. Is it certain that people who overcome the virus get a long-term immunity? Well, we don't know. We know that people have been hospitalized with COVID-19 and who have had many complications usually have a higher concentration of antibodies. But we don't know what that means because that seems to be also some more elderly people. And that's amazing because usually we know that their immune system is less active or start already to suffer from becoming older. So we really need to understand what that means. And the factor of age, the factor of complication is quite important. On the other hand, at the other spectrum of the age, if we look at the situation of children and young people, they almost don't develop any symptom. And the question is there, are they going to be protected? So it's still something that is part of scientific research.
So thank you for answering the question from the chat. It's always great to have everyone involved. So if you have any questions, please put them in the chat and we'll address them. So question 6, in the modern context of rampant social media misinformation and disinformation, do you think the COVID-19 situation can be capitalized on to once and for all eliminate anti-vax sentiments from mainstream society, or do you think the problem will persist or deteriorate? I think before we have the expert advice on this, it would be really nice to see what everyone attending thinks. So I would like you to comment better if you think that the COVID-19 situation will improve the anti-vax problem that we have, as in make it less of a problem, or worse if you think that the situation will become even worse than it is right now, or maybe stay the same. So yes, we're going to start looking at the chat for your answers. It got better, stay the same. And anti-vax will exist till the end of time. Ouch. I think it will depend on the success of the vaccine. Very interesting. Worse in the USA specifically. Better. Okay, so it's a very mixed pot of ideas, and I think that makes sense because it's a very complex and multifaceted issue.
Yeah, it remains complex, but I think, and I see that also in the chat, I think they will continue to exist until the end of time, and I'm afraid that will be the situation, because the COVID-19 situation has also polarized populations. And you see the same kind of polarity in the pro-vax and anti-vax. You have in the population for the moment people who say, oh, the lockdown was not needed at all because it has had a tremendous human and economic costs and social costs. Others say, oh, we are relaxing and easing the measures much too fast and we are afraid that this will cause a second wave. So that polarization is really existing. It's the same polarization that you see about wearing masks. In fact, wearing masks is a bit like vaccination. It's very altruistic. So if you wear a mask, it's to protect someone else, not to protect yourself. And so you see the people, if you look at the surveys in a number of countries about wearing masks, people will say, oh, I think that the shopkeeper needs to wear a mask, but not the client in the shop, not myself. And that's very egoistic. And so that's the same now at the level also of the anti-vax. You see that the anti-vax is jumping on all kinds of complot theory. It has been created by the Chinese people. It has been created by Bill Gates to put a chip in the vaccine so that he can start to follow and to see what happens with everyone. So we have seen that in previous vaccines, but now everything comes together because it's all new. Some people say, oh, it's like a military weapon. We have to be very careful. Others say, oh, we are for herd immunity because that's the most natural way. Let that virus come over and we don't need the vaccine because the vaccine at the end will just protect us temporarily, and the herd immunity will protect us for long term. So you see the old arguments all coming together now related to COVID-19. So even though I think a lot of countries suffered from COVID-19, within those countries you still see these anti-vax groups, well organized, huge network, good communicators. That's the one I received from one of my colleagues. You have a difference between vaccine research and anti-vax mom research. Well, what we have experienced in the past continues. That means one ID, one statement on Twitter is like an expert ID. And it's fake, or it is not validated. And that's very difficult. And so that continues, of course, with COVID-19. So we have to address that in a way that we have to do a lot of fact check system. So everything that needs, and that's also what we have to tell to journalists. So if you start to bring something across from a publication, from what you have seen, well, you have to check it with a number of scientists, or you have to check it with the science, so that when you bring it out, that it is at least well validated. And I must say, in a number of countries, they do understand this, but it's a challenge. So I'm convinced that the COVID-19 situation will not help at the level of addressing the anti-vax. They might even become better organized and stronger. So we will have to organize ourselves in very good, clear messages covering the safety of vaccines, covering the importance of vaccination, and the difference between the vaccine and the natural immunity. I think that will be key.
Great. So in the meantime, we've been getting some really good questions in the chat. I think I'd like to finish off with the final question, question 7, and then we will address these questions we have from our attendees. So, do you think that the similarity of the COVID-19 virus to the influenza virus, but the heightened worry within the population as next winter or influenza season approaches, will positively impact the uptake of the influenza vaccine, which has until now seen very poor uptake rates all over the world? So basically, I'm asking about the effect of COVID-19 on influenza vaccination, but also influenza protocols in general.
Well, I like the question because indeed you see the demand for flu vaccines increasing, although there is no flu vaccine there yet, but people start to go to the pharmacy already and start to ask for their flu vaccine by October, November. And that has never been like that. So the vulnerable people, in particular the 65 plus people, really do want to have their flu vaccine. They start to get their pneumococcal vaccine already. And I would say a year ago, they were not interested at all in that vaccine. And now they really want to take what they can in terms of protection, because they know they are vulnerable. And that's something I've never seen before. So in a certain part of the population, you start to see this, in particular in the vulnerable part. So they are tremendously convinced that they will need flu vaccine. They will need also pneumococcal vaccine. And what might be an issue is that, of course, all the countries already have ordered their flu vaccine at the manufacturer sites. So the manufacturers can now no longer increase their production. And we have to understand that, because usually you order in March or in April, and that has been done. And so now probably all the vaccines that will be produced against influenza will be used. That is clear. And there might even be a lack or a shortage of flu vaccine in the winter. On the other hand, with all the measures taken so far against COVID-19, if we continue to respect a certain physical distance, if we continue to wash our hands regularly every day, that will also have an impact on flu transmission in the winter. And we have to realize that this is very important. So what we are asking now for COVID-19 prevention will have also an impact on the flu epidemiology next winter. And so probably we will see less cases, which would be good, because at the side of the GPs, of the general practitioners, once we do have circulation of flu, it will be quite difficult to know, is this flu or is this COVID-19? Do we have to test? Do we have to put people in quarantine? That will not be easy at all. So again, this is something we need to think about at this moment. how are we going to address flu cases? Are we going to test all the flu cases so that we know whether it is flu or COVID-19? Wouldn't it be good to, if you have a flu case, also to put the flu case in quarantine to limit the spread of flu? So these are quite interesting policy decisions that need to be debated on the spot for the moment.
We have a related question from the audience where we're asked, is there any research from the Southern Hemisphere where it's currently influenza season, somewhere, for example, like Australia, on co-infection with SARS-CoV-2 and the influenza?
That research is ongoing. We don't have seen any results so far. We know that there are cases of co-infection. We don't know whether this has created a lot of additional complications in those patients. So that is being collected for the moment, indeed, in the Southern Hemisphere.
Okay, so I'm looking actually for some questions that we had before. One of them was actually related to the weather. I don't want to paraphrase, I want to read the question. So. Yes, okay. So until now, there are contradictory scientific thoughts regarding this issue of the impact of weather on COVID-19. As we all know, countries such as Brazil and India, which have high temperatures, are near collapse. So why have we been mentioning influenza season, winter, all that? Very interesting question.
Yeah. And there is a whole debate on that. What we start to see, of course, is that this COVID-19, which was expected to perhaps also have a seasonal pattern, seems not to have a seasonal pattern at all. I do have projects in DRC Congo, and it survives very easily in that humidity. It survives in that in that temperature, whereas we were expecting that it probably would just not survive easily and disappear, but it doesn't seem to be the case. So increasingly we start to think that it will be with us independent from the seasons, which is a huge difference with influenza. Yeah.
Definitely, that's very interesting. And I think as time goes on, we'll have more data to back that up because everything is so new, so we have so many unknowns. And I think that's it with the questions, but if you have any questions for us, please put them in the chat. We're quite tight on time, but we'll do our best to answer them. Okay, so there's a question here. What is your opinion about the contribution of children to COVID-19 transmission?
Wait, I'm just replying something.
Okay.
I had an interview now with the radio on the antibodies, so
oh, great.
No problem. Okay, I just informed them that I will be 15 minutes later. So yeah, okay, back to you.
We'll just take this final question because we still need to launch the survey, which is very, very important for both of us. So yeah, children's involvement with COVID-19, as we've seen, children have less symptoms, and we also discussed that maybe they'll have less immunity if they catch COVID-19. So where do we stand on children?
Where do we stand on children? We have quite some information from household studies who have been performed in the UK, in China, also in the Netherlands. Very nice data on the website of the Dutch Health Institute, RIVM, showing that in fact transmission in households is limited very often to transmission between the adults. That's quite interesting. Sometimes also from adults to children, but very exceptionally from children to adults. So that's a very important given. On the other hand, we also know that the pathology in children is really almost unexisting. So if children will be exposed to COVID-19, they will have almost no symptoms at all, even not common cold symptoms. So that's amazing. They will at least even not be coughing or sneezing. So that means that's a major way of transmission. So if they are infected, that infection will remain very often at the individual level. And that's why a number of countries decided even not to close schools during the epidemic. And we know that has been a debate in many countries, and a number of countries closed schools and then started again with the primary school. And I think that is very understandable, because of course at a certain moment in time, you don't know exactly what is the epidemiology, you're waiting for data. But now increasingly, the data show that children are not the motor of the epidemiology. So very often we started in our perception, oh, it is like flu. And we know in flu, the influenza, there the children are really the motor of the epidemic. And so this virus is not flu, it's really something completely different. So every time we have to rethink and to realize, no, it's not the traditional way that we expected. And so that explains also why we were very prudent with children. We were very prudent in closing the schools, but in fact that was not needed. And we can easily reopen the schools. Denmark did so, Austria did so, Germany, also the Netherlands, now Belgium too. I don't know all the other countries, but you start to see by reopening the schools that you don't influence the epidemiological curve. But when you start to open shops and to again open the business and to have people again meeting with each other, in particular adults, that's what will influence the epidemic curve. So the transmission is merely among adults with, of course, the disease consequences, but not that much transmission between children. We also know that children have less ACE2 receptors, and you need to have these ACE2 receptors for the virus. So these ACE2 receptors will even increase with age, but at a young age you have less of these ACE2 receptors. So that's also quite interesting. And a third argument, which is now also coming up, it's a recent paper in Science, is that the benign coronaviruses that are very well present among young children and where they have still very active immunity against those coronaviruses, they seem to offer cross protection through the T-cell immunity. And so 70% of children might profit from that cross protection. And again, that might explain why, even if they have virus, they will be less infectious because of that cross protection. So it's interesting, every week you learn more, but it all goes in the same direction, that the children are not the motor of the epidemic.
Thank you for the interesting insights. And now finally, before we close off, we would really like to take this opportunity, having all of you here, to promote EU JAV's pre-service training of healthcare providers survey. This is a survey primarily focusing on your attitudes on vaccination and vaccine safety and vaccine hesitancy. Perhaps the professor would like to say a word about this as well.
So you want me to say something, or Sarah?
Yes, if Sarah is here, that would be great, actually.
I think Sarah is with us as well. Yeah. Yes, there is Sarah.
Hi.
Hi.
So I will very shortly introduce myself. I am Sarah Valks. I am working for and with Pierre at the Center of Evaluation of Vaccination at the University of Antwerp. I'm also working with Greet, who is online, I have seen, on the EU chat project.
I didn't know Greet was with us, so that's fantastic.
Well, as Enya already said, we are active in the project. We are active in work package 4, which is mainly on the pre and in-service educational activities regarding vaccination. And right now we want to take the opportunity to ask you to fill out our survey, which we have developed for this project. And where we will question your awareness on vaccination recommendations, how vaccinology is organized within your curriculum, and what your personal attitudes are towards vaccination, which is really important in the scope of the project. You can fill out the survey by following the link on the slides or by scanning the QR code. It should take you, I think, around 5 minutes to finish. But it would be a tremendous help for our research. So I really want to encourage you to fill out the survey. Thank you.
Thank you very much. We'll also be passing on the slides and a summary of today's event via the email addresses that you provided. So please be sure to fill that in. It'd be very useful for all of us. And with that, I'd like to thank you all for attending, and also thank our guest speaker so much for his insight and for his very precious time. And that's it from my end. Thank you.
A pleasure.
Okay, so that's it. Goodbye. Thanks for joining us.